So at the SUO meeting this year, we were able to give basically an update of where we stand for diagnostic approaches in molecular imaging, and also some of the emerging theranostic approaches that are moving to the clinic on clinical trials. It's really hard to fit it all in a 10-minute presentation, but we do have many unmet needs in kidney cancer, and we hope that some of them could be addressed with the introduction of molecular imaging. This is really akin to what's been going on in the field of prostate cancer, where we have some immuno-PET agents and small molecule PET agents that could be used for localization and or treatment. The most really exciting aspect that entered the space is CA9-based imaging. This has been long hoped to make its way back to the clinic after a trial showed that there was some hope that it could basically diagnose clear cell kidney cancer on a trial about 10 years ago. And we went over really the ZIRCON trial, which is a pivotal phase 3 trial where we have used immunopet with zirconium-labeled girentuximab, a chimeric antibody which can bind to CA9, which is expressed on the majority of clear cell kidney cancer's cell surface. And that trial did show that the positive predictive value to diagnose clear cell kidney cancer was about 94%. So it is a great tool that would hopefully be available for us to diagnose patients with a small renal mass rather than doing upfront surgery empirically. Now, we also went over the potential ability for it to diagnose patients who have disease outside the kidney, and we're very excited on the many ongoing trials in that space. There are other small molecules which can be used to target CA9, and those are also in clinical development. So it's really an exciting time where we potentially could use molecular imaging to overcome some of our limitations for conventional CT and MRI, or bone scan, or conventional FDG PET CT. So if you can see something, then hopefully you can use that to target something. So it's been used in prostate cancer and also neuroendocrine tumors, where you can have a diagnostic imaging tool, which is coupled to a theranostic agent, where you can attach a different payload to either an antibody or small molecule. And if you can do that, you can basically use something like an alpha emitter or beta emitter that can actually give high doses of radiation to a local region. Now, we've known that has good efficacy in our other fields, such as prostate cancer. In kidney cancer, there's been one trial in a prior era as monotherapy. It did not appear to be effective at shrinking tumors, causing partial responses, but there were a lot of patients that had stable disease. So there are ongoing trials now with either small molecule or girentuximab, which are currently in phase 1/phase 2 trials. And they're hoping that partnering it with maybe immune therapy or other types of agents, TKIs, might potentially potentiate the effects. We do know that giving high doses of radiation could potentially stimulate basically a immunogenic effect, releasing antigen, maybe causing patients to have a more robust response to immune therapy. We also know that in clinical preclinical models, if you actually damage the DNA with an alpha or beta emitter, using something like maybe a PARP inhibitor or an alkylator, you can cause additional DNA damage, which could cause cell death. So we really need to kind of figure this out. We have ongoing research here at UCLA, and many centers are really excited about the effect to partner basically theranostic approaches using either CA9 or PSMA to actually target kidney cancer cells and join it with another type of therapy. So, when we do these trials, clearly, if they're positive, we hope to get them advanced. So, the ZIRCON trial was positive. We're hoping that it goes and leads to an FDA approval. Even if it does get FDA approved, there's a lot of logistical hurdles in terms of getting your site up and running for a special license to use zirconium. You also need to make sure that the company has robust shipping practices so you can be able to transport this all over the US and scale up. The issues logistically for zirconium-based girentuximab imaging is that patients don't get imaged right after they get dosed. So with PSMA or FDG PET CT, patients get dosed, and then within a short period of time, they get imaged. With this agent, there is much cleaner tumor background ratio if you wait, 3 to 7 days. So we do dose patients, and they have to come back for a separate appointment several days later. And logistically, if patients live out of town, it's a little bit more challenging. So coming to a out of town center, obviously, it's more challenging. But hopefully, as more sites get on board and this diffuses throughout the community, patients can receive this type of imaging technology closer to home.